Hello and welcome to Amsterdam, to the International Forum on Quality and Safety in Healthcare. My name's Caroline Ainslie and I'm the Deputy Chief Nurse at South Central Strategic Health Authority. In this panel discussion today we're going to talk about the use of scenario-based simulations as a tool for patient safety enhancement. And I'm delighted to say that joining me for the discussion are Dr. Göran Henriks. Göran is both the Chairman of the Forum's Strategic Advisory Board and the Director of Learning and Innovation at Jönköping County Council in Sweden. Hi, Göran. Frederico, who's an Executive Director and Strategic Partner with the Institute for Healthcare, and Piera Poletti, who's Director at the Centre for Research and Education in Padua in Italy. In South Central we launched a clinical simulation training project back in January this year, and we currently have 7 fellows who are working across our region focusing on our top 5 safety issues. And those fellows have been instrumental in participating in the development of the questions that I'm going to ask the panel today. We're particularly interested in exploring the influence of human factors on patient safety. And so with that in mind, I'd like to ask the panel what they think is the best way to introduce a safety culture. And I'll start with Göran, if you...
Thank you. In the beginning we worked a lot with different kind of methods, risk assessment methods, quality improvement methods, but we felt that the focus became more on methods than on the real culture change. And our experience is that it really started to become a culture when we had the chance to involve patients in our work. And we had some dramatic cases where patients were very close to death because we didn't do the procedures the right way. And one of the patients that are actually here today gave us a deep description how it was to be a patient and knowing that she couldn't help that she came into this severe situation and that it was caused by the system. She was not angry, but she felt very guilty at the same time as she was very happy because the guiltiness came from the relationship to her family, that they didn't expect this severe situation, that it should come up by her visit to the hospital. So it was a dramatic situation for our system, but it helped us a lot afterwards because we started to talk about this and we started to feel the patient's perspective, and that really gave us a new level of culture around safety.
So I think there are several components. I agree with Göran that putting the patient at the center truly changes the discussion. We did an exercise recently on designing a process in the ambulatory care setting, in the office setting, and we had a patient in the room. And as the providers designed the process, we had the patient react to it. And although their intentions were very good, the patient said, but that's not what I need. This is the care I need. This is how I need it. And by designing it in that way, we get much more specific and much better to aid the patient, include the patient. The other aspect about changing a culture is really modeling the behavior that we want. And how important it is that if we have certain expectations, the leadership has to model that behavior, and it models all the way down to everybody in the organization. And it's not just the providers, but there are other people who work in the hospital, even the people who accept you and maybe schedule your appointment. Every layer of the organization has to model a behavior that says, this is how we do our work here, and it's always patient-centered, and it's always focused on doing the right thing for the patient. And I think that would be a great way to get it started. Mind you, it will take time. It took us a long time to get to where we are. It will take a long time now to change the attitudes. But now we're learning how to do it a little bit more quickly.
I agree, and I also think that the key word is people engagement, all the people. And what we need is a vision of the system, provide education, provide tools, also to have the people seeing how they are, what they need, what they want, aim to, and to be proud where and how they are in order to decide what next for them and for us. So my key word is people engagement and provides tool.
Thank you. Frank, maybe I could start with you by asking, what do you think the role of human factors training specifically is in improving patient safety, and what would that training look like?
That's a great question. Human factors, and to be clear, what we mean by human factors, at least the way I like to interpret it, is the interaction of humans with humans, people with people, interactions with humans in the environment, interaction with humans and machinery. So there are individuals who have spent a lifetime, a career of studying human factors and how to relate and how to design equipment, etc. I don't think we have the time to do that, but there are little things that we can do to help people understand that relationship. So as part of an exercise we do in our Patient Safety Executive Training Program at the Institute for Healthcare Improvement, we identify what are those human factors violations, those things that cause people to be set up to make an error. Things like fatigue, things like not getting enough sleep, things like maybe even taking prescription medications that may affect your judgment, distractions, noise, those things. We tend to highlight those as a means of showing people this is how you get into trouble. We then have an exercise where we have these people go out into different areas to look for those things. And they come back with a very different vision of what could contribute to harm. So in the Human Factors exercise program, yes, we'd love to teach everybody all of it, but I think a more effective approach would be let's raise awareness of the things that get you into trouble. Because many times, many of our workers don't even realize that multiple distraction, they just accept it. This is what happens. Instead, if they become aware that that's a problem, they can then think about how do we fix it. The other aspect is interaction with equipment. Equipment designs aren't always ideal. And how can we work with our staff to look at how to use the equipment? How do we work with industry to better design the equipment? I think those are all key elements because we are humans after all, and we take that baggage with us wherever we go. And if we don't understand how we work, how we relate to each other, teamwork and communication training has been an effective means of getting people to work together and address some of those human factors issues. So it's an all-encompassing component that I think needs to be part of all of the work that we do to reduce harm and reduce errors in healthcare.
Thank you, Frank. That's a very comprehensive answer. Building on that, I wonder, Piera, if I could ask you to give us your views on whether you think simulation-based training has a role in recruitment of clinical staff, particularly for the non-technical element of roles.
Yes, thank you, because I am working on technical skill right now, and I think that simulation is very helpful. Of course, I think that we need to use simulation from the beginning, first of all, to assess the needs of people, and then to develop and offer opportunity to train through simulation. So also to evaluate and let people have the opportunity to assess their skill, their way of working, and so on. So I think that this is a very important tool. However, we need also to develop specific project or courses or training in order for the different setting. We have a lot of opportunities to have a general project or general training, but it has to become a setting specific tool, not just a general tool. And also to have people possible from the basic training to be aware of this kind of training opportunity and become familiar with. Otherwise, they see this like something that they have difficulty to deal with. So, in my opinion, is the tool for the future, but we have to learn how to best use this in every single step of our, of course, training and retraining, because sometimes we have people coming back or moving from one unit or from one department to another, and they need to improve or to get very soon the different or new skills. So a simulation can be a very good tool for us.
Thank you.
I have an example of a hospital that we visited in Massachusetts back in the United States that had adopted a model simulation mannequin, and they were able to demonstrate that they cut nursing training time by 1/3 just because they were able to get those situations, just as Piera mentioned, that the nurses were able to actually hands-on practice with the dummy and get a level of expertise that they would have had to wait so long to get it. The other aspect of a simulation that I want to make a point about is that we tend to think for high-tech simulation. We tend to think of high fidelity, we need mannequins, we need big rooms, and I would say there are those situations where that is extremely important and necessary, and it sets the right scenario, so we have operating room and we may have other situations. And then there are some very low-tech, low basic simulations that you could pull off at minimal cost. And I say that because hospitals will say, well, we have to get a simulation center. It's a great thing to do, but you could still do some simulation without the simulation center.
Yeah. Yeah. Yes, I agree. Göran, I wonder if I can ask you, how do we keep our clinical leaders engaged on an ongoing and continual basis?
For us, it has been very important to find measures that visualize how the work goes. And then I think you have to be a little open-minded, because it's not measures that are scientifically very strong, but measures that shows how well we do things in a process. And when you start to talk about measures, the leaders also get engaged in why do we measure and what are our aims and what are the purpose of these measures. And those kind of dialogues prepare the language, but also the perception of what is important for us to do. So by having dashboards that describes each entity's interest in safety, helps the leaders to also find their role in safety work. So I recommend strongly that you, parallel with the safety development, also develop your support around process measuring. That is very important.
And what sort of things should we be measuring?
It's, I think, a very good question, because what gets measured is what gets focused on, and whatever we are. From the safety world, what we've looked at is mortality reduction. It is somewhat, some folks will say maybe it's not the right measure, but it's a measure that we would want to focus on. How well are we doing? Harm reduction. Are we reducing harm? So it gives us a focus of addressing issues that are causing problems for our patients or adverse event. And I want to reemphasize what Göran is saying, is that depending on where you are in the organization, you have to customize the measures for those people. What gets their attention the most? Because if you are somebody at the front line, you probably are much more interested in getting my job done. What are the processes I need to get the job done? But it's leadership's responsibility to make sure that they all tend to roll up to the ultimate goal of what does our organization want to achieve around improving quality and safety.
In my opinion, in my opinion, it's very important that the outcomes and the result are discussed by all the team, because in order to be proud to be there and to work together and to carry out our work at the best we can and to do our best with the patient, the key is to discuss the result together, to decide what to measure together and to have the result to discuss. Often this doesn't happen. So I think that the key word, again, is to engage people, because they have to discover their talent, to be proud of their work, and of course learn through their work and through other educational tool or new tool that you offer them, for example, through benchmarking, through comparison to other opportunities. But we have to be proud of our work and improve our work. So this is my key message.
I agree with Piera here. And an example can be how we now have worked with better hand hygiene, and better clothing. And 95 to 98% of our staff members now have the correct clothes, and 90 to 92% of our staff always do the right hand hygiene. Our hypothesis was that this should help us to reduce our care-related infections. But now we see that we still struggle with the care-related infections. And I love that, not a conflict, but that dynamic that develops when our hypothesis doesn't work. And you get that kind of discussion that Piera talks about now in the system, because that develops the safety culture. Because we see that we cannot live with the care-related infections in the way we have them right now. So measuring is the start, and it's good if it's not always giving you the results you expect.
And I will add that we tend to sometimes measure too many things and not really understand what are the right things we should measure. And again, reinforcing what you say, we may be measuring hand hygiene, but if it's not giving us the outcome we want, then we need to rethink. And I think a lot of organizations fall into that of, we have tons of measures, but don't know how to interpret them, don't know how to align them, don't have engagement from everybody to agree these are the right measures. So it's that essential few. What are the things you really need to understand to look at your organization, and are we providing the care that we want to care? So lots of little things, and even how you display the measures is a critical element.
To me, that thing is important also, that every profession can contribute, because often we work and analyze and assess, for example, the general outcome, but also every profession has to be proud or to contribute to say something and to measure their own contribution, and also to assess if people, or of course patients and other stakeholders, but our people, are they fulfilled with the work they do? Because this is the key. We talk about human and the people, but we need also to assess this, offer a measures, and give feedback to this too. So many elements to be measured.
Yeah. The hospital obviously is a productive unit, and there's a lot of attention on efficiency. But does this have a cost, and is it a calculated risk?
To start with, this focus on production is a little dangerous, because all good business have three logics. It has a production logic, it has a business logic, and it has a innovation logic. And when you start to focus on only one of the things, it is a little dangerous. And I think that if you should develop a safety culture and become more safe, then you have to have all three logics in your language and in the leadership, so you balance this a little. We know that when we become more lean or more productive, to a certain limit, that is very good, but it can of course also stress people, and then it becomes dangerous. So there has to be a balance in this approach, I think.
I think there's a lot of waste in our systems. No matter where you are in the world, you're going to find that waste. And when you talk about productivity, people tend to think we're taking steps away, we're doing... I think if we better design the care we're going to deliver, if we better manage how we deal with patients, if we reduce some of the harm that we're causing, we're going to free up time. And although in some cases it's just my theory, I think a lot will support that and say we can streamline, we can simplify, we can standardize. And as Göran said, there are some things that you don't want to give up, you don't sacrifice just for the sake of productivity. But I believe very firmly that we can be more productive if we are more efficient with what we do, and that efficiency means let's find less complex way to deliver care that's still reliable but doesn't put the patient at risk.
I teach my students at the university that they need from the beginning to be able to show the cost and the benefits of every choice they make. This is because I think that you have, of course, if you put our resources in one area, we do not have resources anymore for others. So to be all conscious of this can allow us to find the best solution, also to use the resources in a positive way, not just let the people feel, for example, with what happens now with the moral distress, that they think they do not have the resources to do what they aim to or the best for patients. So if we teach all or all together, have the mentality to show the benefit and the cost of one solution instead of another, and together work on the system and of our work, we can, in my opinion, improve the care and reduce the cost or have the best use of resources, not just reduce the cost. Otherwise, we get people into the moral distress. I cannot do what I am aiming for. So it's a huge problem to me.
I think that concludes our questions for today. So I'd like to take the opportunity to thank the panel, Göran, Frank and Piera.
Thank you.
Thank you very much.